morning or good afternoon, wherever you're at. Welcome to our first PRISM STD Information System Users Group meeting of 2016. We're excited to have everybody here. So far, we have 18 people on the line, so that's a really good turnout, and probably a couple more people will be joining us. If for some reason you can't hear me or there's a problem, use the chat field on the left, and my colleague Marvin will be sort of looking at the chat messages, and if there's any message, he'll kind of interrupt me. So if you can't hear or there's interruptions or whatever, we do have all the phones muted, so we don't have any distractions. So the best way to do it is, if you have any questions, make sure you use the chat function. Again, please make sure your phone is on mute, just in case we unmute the phones. There's not chaos, we can hear everybody. If for some reason I lose my internet connection, Marvin should be able to take over and control the session, so we should be okay. And then I'll try to get restored back. And then again, please use the chat function. Most of you are, have long-term members of the PRISM Users Group, but I know we have some new people today. So just a few things about, what the group is about. We started this group to make sure that any of the apps-funded STD grantees that use PRISM as their primary STD information system sort of have a forum to share best practices, solutions, get technical assistance if they need it, and most importantly, dialogue with each other, you being the project areas, as well as with CDC's Division of STD Surveillance and Data Management, and us at NCSD, and now we are including Advanced Systems Design, or ASD, as the vendor. So we're really excited about having them join the group, and so we can have a really good dialogue. And again, the purpose of this whole group is to help enhance everybody's surveillance systems so they can be the most accurate. One of the things we always try to do is have a couple of poll questions. So we like to try to figure out who's on the call as far as our audience. If you could take a minute and just indicate which primary work environment you work in, so whether you're a local health department, state health department, vendor, et cetera. Mark one of those, and then we'll take a look and see where our audience is. And so we'll give it about 10 more seconds. So over half of you are from state health departments. And I just want to remind everybody, if you have colleagues at a local health department who are PRISM users, feel free to invite them if you would like to the group. And about a quarter of the people are from CDC, and the rest are vendors or non-governmental organizations. So that just gives us an idea of that we are sort of reaching our target group, which is primarily the state health departments, state and local project areas directly funded from CDC that are using PRISM. So let me quickly review our agenda for everybody. So the first thing we're going to do is have a welcome and introduction. And while we're on the welcome and introduction, I'm going to do a quick roll call by state. And just as I say your state, although it's not really going to work since everybody's phones are muted. So I guess we're not going to do a roll call. I guess the best thing to do is if you could just go to the chat function and type in what state you're calling in from and your names. We'll be able to, sometime during the call, we'll be able to look at that and get that so we can do have that. But obviously a roll call is not going to work when we have all the phone muted, which we just kind of figured out now. So the next thing is I'll do a quick update from NCSD. And then Marvin's going to do an update from CDC, from the Surveillance and Data Management branch. And then we're going to hear from James Crowley from ASD, who's going to just give us a short update, and maybe we'll take a couple of questions for ASD. And then we have our feature presentation is from Sandra Mattis from Maryland, who's going to talk about using linkage to care in PRISM. And then we're going to open it up for questions and discussion. Again, we'll have to use the chat function. We might try to take the phones off mute. We'll have to see. And then if we have time, and this is only if we have time, we want to sort of get some feedback on what people's experience has been using NPIN. The main thing I really want to communicate, though, is if we get into a discussion, we will continue to that. These calls are really to foster a dialogue and give you guys a chance to question. So we don't mind amending or changing the agenda, and if we need to, we can run over a little bit for those who can stay on. But the main thing is we really want to make sure there's time for good discussion and questions. So let's, without further ado, quick update from NCSD. We really continue to support both the PRISM and Maven users groups. Those are the two big groups that we have going, and we have probably about 13, 14 states in each group with, I would say 30 to 40 people in each, participants in each group that we have listed. Sometime this week, I will send out a revised list of all participants with all your information. If everybody could review that list, it's an Excel spreadsheet. Look for any corrections, any changes in phone numbers. If somebody's dropped off the list, please let us know, and then we'll also add new people. And again, the purpose of that list is not only for us, to be able to communicate with you, but it's also a really great resource for you. If you see that another project area is doing something and you want to talk to them, this gives you, ready access to be able to pick their brain and see what's working and what's not. So, we'll be, in 2016, we'll continue to support the users groups. We did have a surveillance session at the NCSD annual meeting last October, it was October, in Savannah, where we had a really good update from a number of users as well as CDC sort of about what's going on with surveillance systems. And then we actually had several breakout groups where we had a PRISM group, we had a Maven group, we had a NEDS-based group and some other things. And we had a really rich dialogue. And again, I think that's one of the ways we sort of hooked up with ASD and, got buy-in from everybody that, they thought it would be really good to have them start participating. So that's sort of it from NCSD. If you have any questions or need anything from us, technical assistance, my email will be on one of the slides towards the end of the presentation. So we're really excited to help support these calls in conjunction with our partners at the Centers for Disease Control, Surveillance, and Data Management branch. So without further ado, let me turn it over to my colleague, Marvin Fleming. Marvin?
Hello, everyone. Before I get started on here, let me say that for the most part, I am just giving a heads up. These are updates. I'm not going to be an expert in all of these topics, so if there are questions, I'll probably have to make note of them and do some follow-up in order to get some answers for them. Next slide, please. Okay, the first update is going to...
Can you see it?
It doesn't look like it's moved.
All right, let me try. Give me a second.
Okay.
Those of you who have information systems, there's always technical issues. It looks like having trouble getting, okay, there we go. Let me get back.
Yeah, go back a little bit, please. Okay, yeah, one more forward. There we go.
Okay.
Okay, the first update is going to be on the message mapping guidelines. There's not a lot to update. As most of you probably know, in the fall of 2015, the project changed vendors, and the new contractor is still getting up to speed on the MMG process. This has caused a delay to the project, and it's now estimated that the MMG will be released sometime in spring of 2016. Unfortunately, that's as specific as I can get. But as far as the congenital syphilis and the STD MMGs, they are considered to be at stage 2, which is the pilot test ready draft phase. The draft guidelines and artifacts are provided to the local, state, and territorial jurisdictions that are part of the NMI pilot testing process. But the guidelines are also available online. And when you get a copy of these slides, in this section, anything that's underlined is hyperlinked. Next slide, please. So when you click on where it says Stage 2 on the previous slide, it should take you to this website. So even if you're not part of the pilot testing process, you can still come to this website and get updates on what's going on with MMG. Now, since this is an ongoing process, things are in flux. So what's on the page may change from week to week. Next slide, please. Okay, the next update is going to be on ELC. That's Epidemiology and Laboratory Capacity Health Information Systems Project. The ELC project will be setting up calls to review 2015 ELR volume collection data. Information will be coming to the documented ELC coordinators within each project area or site in February in order to prepare for the 2015 spreadsheet. Calls will be scheduled between March and May of 2016. What's presented on the screen now is a list of current STDs that are counted as far as the volume for laboratory. The reason for sharing this information with the user group is so that you are aware of the role that STD is playing in this national project, and to encourage conversation at the local level as you are the subject matter experts as far as STDs. A few other details. When referring to volume, volume refers to the number of laboratory tests. Volume does not refer to the number of results. Volume does not refer to the number of cases. Volume will not include duplicate reports. And, as specific to your project area, volume does not include reports received that weren't reportable. So if you look at this list, you may see some conditions on there that for your project area, they're not reportable. So you wouldn't be responsible for those. Next slide, please. The last update is that CSTE and DSTDP will hold the next surveillance coordinators call on February 8th at 1 p.m. Eastern Standard Time. And as you can see, the connection information is on the screen there and will be on the slides when you receive them. This information was sent out to all of the project areas. We just wanted to make sure that you were aware of the calls. And that's it for DSTDP updates for this time around. Back to you, Charlie.
Thanks, Marvin. All right, so now, and this is the first time we've done this, we're going to have an update from ASD. And so, James, take it away.
Do you have the right James unmuted?
I can hear you, so I think you.
Yeah,
you
but
do.
I'm not James Crowley. I'm James Mathias from Florida.
Oh, okay. Sorry.
No problem. I don't know if ASD has a different line.
Yeah, okay, sorry everybody, we'll figure this out. And maybe that's, so Marvin, if you can help me look, we're looking for 385-5129, I think, or might have changed. James, if you could chat me your phone number, because we might have unmuted the wrong phone. Okay, so it's 5129, if you can see it, Marvin. I'll look too.
I'm looking through the list as well.
So while Marvin's looking, just one thing I didn't mention in my update is there is going to be a syphilis summit at CDC in about 2 weeks, where they're going to kind of look at some of the recent increases and try to figure out where to go from there. If people had any issues related to syphilis surveillance, especially related to going in regard to that would help to improve syphilis surveillance, you can email me and I'll make sure that that information gets down to CDC or gets brought up when we have discussions. So just want to let you know that. So any luck yet, Marvin?
No, I've gone through the list twice, and I'm either I'm just overlooking the number or I just don't see it.
Okay, I'll look too. So again, we apologize, but this is technology here. Okay, I'm not sure I'm seeing. So here's what I'm going to do. Okay, I'm going to unmute all the phones. That means, first of all, everybody, if you would all mute your phone except for James. Because if one person has their phone unmuted, it's not going to work. And then we'll see if we can we can make it work. Okay,
Charlie, I just unmuted the number that Mary White gave because I've gone through the list several times and I don't see the.
Okay, James, can you hear us? Or Mary?
I'm on the line. This is Mary.
Okay. All right. So I'm going to mute everybody's phones then. So make sure everybody's phones are muted on your end, and then James, make sure yours is off.
The conference has been muted. The conference has been unmuted.
Okay. So James.
Hey, can you guys hear me?
Yeah, except you're a little bit faint. If you could maybe get closer to the phone. Or.
Okay. All right. I have apologies. Is this any better?
You're still. It's not. We can hear you, but if you could maybe a little bit better.
Okay. Is that any better at all? If not, I'll call in from a different phone. I'm so sorry about the technical issues here.
Unless if anybody really has a lot of trouble, send us on the chat. But I think we can hear you enough that I don't want to delay the call too much more.
Okay. So just to give everybody a little background on our relationship with PRISM is just ASD employees have worked on the project for almost its entirety, including Mary White, who everyone is familiar with. And she will be joining us in-house in July, which means she will be leaving Florida Department of Health to come work on PRISM full-time in our team over here. But I'm just going to jump right into what we've been working on. We have stood up a demo and development site so that if anybody would like usernames and passwords to those, I do have to give those out myself. But there's now a centralized public facing PRISM instance so that as we start adding new features and developing on the site, it's open for feedback, for people to look at it. There is no real data in there, and one of the things we are working on is developing an automated process for creating test data, which is something that I think is problematic for some states because the process to anonymize the data and scramble it is fairly complicated. But since we have started our development cycles, we've made a few back-end changes to error handling to kind of reduce the effects that errors have on the server side. We're now starting the process of modifying some of the risk input fields so that when you're filling out the risks, if the client refused to respond or was unavailable, it will auto-populate a bunch of the Gantt questions. We are also bringing in some stuff that Florida is working on, which is allowing the edit of a field record treatment to help with end-of-year cleanup, hyperlinks in the end-of-year reports. We are also working on drawing up requirements for deleting field records and internal records from within the application. So we haven't had an opportunity to really hit the group outside of our customers for who have our support contracts. So one of the things that we would like, if there is some time, or we can take this offline if it gets out of hand or anything, but we really want to facilitate the conversation with the group as a whole, not just with our customers. And we're open to ideas and suggestions about how best to do that. If InPin is the forum that people would like to use, or if there's something else, let us know. But we are committed to supporting PRISM, the application itself. It's always going to be open source, but we really think it's the value that we're looking for or looking to add is going to come from the group as a whole contributing, not just a few states here and there. So we would really like any suggestions, ideas on how best to do that. And other than that, I mean, if anybody has any questions for us or wants any more in-depth information about what we're working on, please let me know. I can provide any of those logins, like I said. And if anybody has questions, concerns, comments, feel free to raise them to us. But we're just really here trying to support the community and of the PRISM users and the application as a whole. So don't view us as as necessarily a vendor. I mean, we are, but we're contributors rather than we're not owners of anything. We're here to support, and that's about it.
Thanks, Jamie. I think we really appreciate the collegial spirit that you guys are coming with. Since we are experimenting today, and we have the phones unmuted, if anybody wants to ask James a question, unmute your phone. We'll open it up for about 5 minutes, and then we need to move on. But if anybody has any pressing questions for James or ASD, let's take a minute or two to you can go ahead and unmute your phone and ask the question. So we'll wait another 30 seconds, and if we don't hear anything, we'll move on. And again, if you think of something while we're talking, you can send it in the chat. And Marvin is kind of looking at the chat messages, and if there's any questions, he'll interrupt and okay, hearing none, we'll move on. And our next talk is going to sort of be on linkage to care. So before we get started, we just wanted to have an idea of whether your health department is currently tracking linkage to care. So if you could just take a minute to, mark a response, or if you're not doing it, just mark not applicable. But it's the responses are either you're using the newest PRISM version with linkage to care records. You're doing a locally developed PRISM adaptation to accommodate linkage to care. You're using another database to track linkage to care. You're not tracking linkage to care or not applicable. So just take a second to sort of mark your response, and we'll see where we're at. Okay, somewhat interesting. About a third of you are using the newest PRISM version, which I think does have some linkage to care functionality. About 10% of you have some locally developed adaptations to allow you to accommodate linkage to care, and about a third of you are using another database to do that. So that gives us a little bit of idea in our next speaker, who is Sandra Mattis from Maryland. And so, Sandra, do you want me to advance your slides, or do you want to?
I will try to do it, and if I have problems, then I'll punt it to you.
Great, thanks. So take it away.
All right. Well, so I'm Sandra Matthews, and I have with me also Richard Bradley, who has recently joined our health department as a part of our PRISM team, our PRISM support team. And so we were asked today to talk about the linkage to care function that was added to the newest version or newest-ish version of PRISM. That's what we'll be talking about today. And here's our mission and our vision for the Maryland Department of Health and Mental Hygiene. And then we always find it pretty useful just to learn a little bit about the project areas that our report are giving a presentation. So here are our kind of our morbidity numbers. in our rankings. We ranked 3rd for HIV and 8th for syphilis in 2014. And for gonorrhea and chlamydia, we kind of hang out in the middle. And here's kind of a map of where our GIS and our linkage to care staff are stationed. Note that Baltimore City, that's kind of in the middle of our state, is a separately funded project area for both STD and for HIV, but we are all in the same system. So Baltimore City staff use PRISM, the same instance of PRISM. We see everything, in the same one system because, as we all know, the disease doesn't stop at a city limit. So you'll see that we have the green counties are kind of our high morbidity counties, and you'll see that they basically are those counties that surround Baltimore City and Washington, D.C. And the blue counties are our lower morbidity counties, and you can see that only our higher morbidity counties have specialized linkage to care staff. All of our partner services investigations, so both for syphilis and for HIV, are managed in the PRISM. Our newly reported HIV cases are offered partner services and assisted with linkage to care, and we have staff, either DIS or linkage to care workers, who will also help previously diagnosed HIV cases get engaged with care. And then all the medical appointment attendance is verified and documented in PRISM. So one of the first things that we added is something that Baltimore City had been using for a while, and we call them the triage questions. And so it's 3 questions. Is the client aware of his or her HIV status? Linkage to care, is it needed? And is a partner services interview needed? And so the answers to those questions kind of help us understand how to approach each investigation. And there are also edits associated with it, so that if you say yes, linkage to care is needed, then you can't close that field record without creating a linkage to care record, for example. Linkage to care records are treated kind of like labs are treated in PRISM, so that you have, it's like a separate sub-tab in PRISM. Right now, ASD just modified it at the end of last year so that we can use it for HIV or hepatitis C, because Baltimore City is doing some linkage to care work with hepatitis right now. So having it as this kind of separate record allows you to, the DIS or whoever's working the case, to close the field record quickly in our kind of typical 2-week kind of timelines, but leave the linkage to care record open, or if they can close the interview but the linkage to care is still open, then that work can be separated, and so the partner services disease intervention work is not, those kind of timelines are not impacted by the linkage to care, which can take a little bit longer. And you can also reassign the linkage to care record to someone other than the DIS who is doing the partner services work, if that is the way that your county or state is working currently. So it allows for that flexibility, which is nice. And so again, like labs, there's the linkage to care. You can select the linkage to care records that are associated with this disease episode. And then there's also an all linkage to care tab, so that you can see all the instances, all the linkage to care records that are associated with that patient. So this next slide is just a screenshot of what it looks like, the linkage to care record in PRISM right now. And so we'll kind of talk about these different aspects, and we'll start off with this kind of the first one that says a reason not referred at the kind of the top-ish area. And so that's obviously completed only if the client was not referred to care, and if RD cares is selected, then there are certain variables that are required, and if the reason for not being referred to care is anything other than already in care, so deceased, moved, refused, or unable to locate, then only the referral outcome, which is at the bottom of the screen, is required. And then we come to referring provider and the care provider. The referring provider is the provider that referred the client to care. Often that is the agency where the DIS works or the linkage to care worker works. But sometimes that's not the case, and so if it's not the case, then you can document if it's someone different. And then the care provider is who provided the medical care. And just like on the field record, there is, which is also I think a new feature with this latest version of PRISM, there's also contact attempts on the linkage to care record, which you see when you're in edit mode. And so if you've already documented your contact attempts on the field record, you probably don't need to repeat that here. But if it's different people doing different work, then you they can document their contact attempts in this separate place also. And then at the bottom of the screen, there's the results section. So it's kind of the final referral outcome of this linkage to care event. And then the verification source and the date that the referral outcome was verified. And if you selected attended appointment, then there are certain variables that are required. And there's also a notes section on this screen so that the people who are working the case and trying to do the linkage to care can put in whatever notes that they need to there. So whenever a linkage to care record is created, a tracking notification is created on the user's task list, and it stays there. So it's not in there's not like a special kind of linkage to care section, but it's in the notification section, which is above the field record section on the task list, and so it remains there until it's closed by the assignee and then the requester. The person who created the linkage to care record. Often that can be the same person if it's a DIS who is doing the partner services and the linkage to care, and then they'll have to close it both as the assignee and then the requester. But and then if it's a different person, for example, if it was a DIS and then they were able to give the linkage to care aspect of the case to someone who specializes in linkage to care, then that they would start that linkage to care record, and then they would know when that linkage to care event has been closed and worked by that linkage to care person, and then so they'll know the outcomes of that referral. And so this is just another screenshot of of all those pieces that we just talked about, kind of put back together. And that's all that I have. Unless people have questions, we're happy to answer any questions of how we kind of implement it and that kind of stuff.
Thanks, Sandra. Since we had the phones unmuted, if anybody has a question.
Hi, this is Terry in New Hampshire.
We can take. Okay, go ahead, Terry.
I have a question. On the linkage to care, do you have the opportunity to reassign that record like you do with field records and interviews and labs?
So, yeah, I believe so. So that so you can have the field record assigned to one person and then linkage to care assigned to someone else, and then if it needs to be reassigned to someone else, you can do that.
So the linkage to care, is that embedded within the field record?
No, it's a separate record.
Okay.
It's like a lab. It's treated very similarly to a lab.
Okay. Thank you.
Great question. Other questions from participants? Or, if somebody else has done linkage to care a different way or wants to talk about sort of what they've done in their jurisdiction related to PRISM or something else, we could probably take a couple minutes to have a discussion on that.
Well, I also probably so I think there is talk of adding I think another maybe variable in the linkage to care area, and
Hi.
Mary or Megan, feel free to chime in
Okay.
to kind of be able to differentiate kind of the
10:30.
like if work that's for P4C versus kind of other linkage to care efforts, so you can kind of tease apart that. I think that's coming.
Okay, I'll see if
down
they're
the road.
making veggie burgers yet. Okay.
This is Mary White. Yeah, we are going to be adding some features for P4C coming very near in the future to help with that.
Great. Thanks, Mary. Other questions or comments? And remember, if you're not speaking, please have your phone on mute because we are hearing some background conversation.
Filtered water? I'm not sure.
Okay. Can you please mute your phone so we can continue? Thank you.
Okay.
Any other questions for Sandra or any discussion?
See you later. Good.
Good example of why we have to mute the phone. Sorry, everybody. Any other questions for Sandra? Okay, thanks again, Sandra. The next thing is we always have a little bit of time on our call to have some discussion about other issues that people are having with PRISM, new developments, something that somebody's done that's really cool that they want to share with anybody. So, again, we really need people to participate on this. Anybody want to ask a question or tell us about something you've done recently that you think might be of interest to anybody?
Sure, this is Jim Mathias in Florida.
Thanks, Jim.
So a couple of things that we just wanted to mention. One is still in our test phase but could be coming soon is we're piloting having a way to capture rapid syphilis test results in a project type manner so that it'll allow us to capture additional details as to the outcomes of the test and different risks that may have been associated with those that were both positive and negative, and that's something that we're looking to add here in the next couple weeks. And then I know James kind of briefly mentioned some of the stuff we're doing in Florida as part of the ASD update, but one of the things we recently did in November was start to require more fields to be used before a case can be closed, and we're looking to evaluate that in data quality. And some of those fields include the risk section for the syphilis and HIV interviews, because we also developed a more smart questionnaire with auto-population of negative results and things like that in Florida, and looking to see how that changes our data quality.
Great. Anything else? Sounds like a lot.
I think that's all I'll add there. So.
Okay. All right. Who else wants to add? I mean, that's a good example of sort of what we're looking for. You know, it's not bragging, but it's also kind of letting people know what kind of innovative stuff people are doing, as well as if somebody's had a question or ran into a roadblock. This is a great time where you can, you know, get the colleagues who are using PRISM to sort of hear about your issue, and maybe they've got a solution to it. So I'm going to wait a minute and see who else wants to volunteer, as well as if there's any topics that you would like to have us have somebody present on a future meeting. Now is a good time to sort of let us know so we can have a discussion.
This is Terry in New Hampshire.
Hi, Terry.
I could just offer up some upcoming CRs we've got coming for probably May or August. Haven't really settled on it yet. In the code admin module, we're going to be getting symptoms there in the same way that we have like the ELR, and we're doing test types, test sources and such. We're going to be able to modify the symptom table as well from the user end here. Plus, in the same way that we have labs and all labs in there, and I think the way that Marilyn was showing us the linkage to care and all linkage to care, we're going to be doing the same with notes and all notes. When you look at the patient profile, you'll see the all notes, and when you click on the field record, you will be able to click the notes tab there. Yeah, just like what we just saw there in the view. when you click on the field record and you click notes, you'll be able to see the field record notes, interview notes, congenital maternal notes in just one shot rather than having to go page by page by page. Those are a couple we're having coming up soon.
Great.
I think from Maryland,
Go ahead.
that's great. That having the notes in one place, I think that's a great idea.
Yeah, that was our public health nurse that came up with that idea.
So is that something you can do locally, or do you need ASD to set it up, or what?
That's actually our contractor that's doing that.
Okay. So if anybody has any questions about how you got that done, they can just email you.
Yep.
Great. Okay, other questions or things that people want to tell us about what they're doing? Okay, so hearing none. So, as you know, one of the, and again, in the interim, if anybody has, you can always email Marvin or myself if you have a question, and we can try to outsource it to, ASD or to another state that we know is doing something, or another good way is to post that question on NPIN, which kind of is a good segue to our NPIN discussion. So as most of you know that we have been evangelizing the value of NPIN as a really good tool to sort of post material, share resources, data dictionaries, et cetera, with PRISM users, because we did create a private group on NPIN, and really promoting it as a way of, if you have questions, maybe to get some real-time answers and technical assistance. So, over time, we know there have been some issues with NPIN. I think some things have really worked well and some things, need some improvement. So Marvin's going to lead a discussion in a minute. I got a couple of quick poll questions so we can gauge the temperature of our group, and then we really want some feedback on NPIN and some suggestions that we can give to them about what's working and what needs to be done to help improve the system. So a couple quick poll questions. How often have you used NPIN, the NPIN site, especially the PRISM site, over since we started? So if you could just quickly respond. So almost a little over a third of you have not used NPIN at all. I don't know if it's an issue that you don't know how to get on, or you just haven't. You looked at it. Looks like a couple of people have used it one time. About half have used it 2 or more times. So I think if you haven't used the NPIN site, we'll send out instructions on how to register for the site. Again, the purpose of the site is really, once there's kind of a 2-step process. You register for NPIN and get accepted to the general site, and then we've actually created a special, what we call private group, that's specifically for only PRISM users that, we've actually, NPIN notifies us, and you can see all the PRISM questions and have access to resources. People who are generally have access to the site won't be able to see the PRISM stuff. So we think the site could be real value. So one more poll question is, so just generally, for those of you that have access to the site, we want to get an idea of how satisfied are you with the NPIN site. So very satisfied, somewhat unsatisfied, very unsatisfied, or you haven't used it. So if you could give us a quick feedback on this. So again, I'm almost happy you haven't used it. Again, we would really recommend that you sign up, because I think not only is there good information for PRISM, but most of the time, almost everybody that we sign up for the PRISM group, there's actually 5 STD groups. One of them is STD Technical Assistance. And so almost everybody that I sign up for the PRISM group, I also sign them up to that group so you can see what's going on and information like that. So looking at about half of you are either very or somewhat satisfied, which is good, but there's still some, looks like only about 10% of people aren't satisfied, and then the rest haven't used it. So I think that gives us a little bit of feedback. So Marvin, if you want to take it away with some questions you have, or maybe a chance for people to give us some feedback on what's working with NPIN and what do they see as their frustrations, or what could we suggest to them to make it a better system?
Okay, thank you. I did speak with the NPIN group last week, and there has been some changes as far as the leadership. They have a new CDC person that's over it, as well as the administrator is a new person. But some of you have given me calls and messages to express some comments about the site, and so I did discuss those with them last week. One of the things that one user was frustrated, or at least one user was frustrated with, was that having to log in after clicking on the link to the emails. The reasoning behind this was that since we belong to a private group, there should not be another security barrier in place to get to the post. And one of the proposed solutions to this was to eliminate the need to log in after clicking on the link. It should just go directly to the post. And the second solution, proposed solution, was to include the complete post, including any attachments in the email, so that users can decide if they need to continue on to the site and then click on to, add their password in order to get onto the NPIN community. Another suggestion that was given that could potentially help as far as usage of NPIN is if there was a Remember Me function added to the login, so that each time that you logged in, you wouldn't have to put in a new password. There was also a request for an enhancement to allow users to add attachments when commenting on a post. As it is currently, if you comment on a post, you can't add an attachment to that comment. You'd have to start a completely new post. And that breaks the line of conversation. Now, one of the biggest complaints that I have received as far as NPIN is that users have tried to post, and after multiple times, it doesn't seem that the post goes through. Some users have sat and waited like an hour to see if a post would go through, and it has not gone through. When I spoke with the group last week, they did say that they have been working towards making the system more stable, and hopefully in the future they will be able to provide some of the updates that we have asked for today.
Perhaps, Marvin, we could, since we have people on the phone and unmuted, a chance for people to sort of, who haven't weighed in, maybe tell us either what's working or what they would like to see changed. So,
oh, most definitely. And before we do that, I will let you know that I did invite some NPIN people on the call to attend for the last 15 minutes, and I do see that at least one of them is on the call. So this will be a great time to share your comments and opinions on the NPIN site.
Hey, Marvin, this is Mary McFarland.
Hey, Mary.
When we did STD prevention online, I can verify that the login is the death of the site. If people have to have a password and a user ID for yet another site, they don't want to be a part of it. So I just wanted to add to that voice. But also, one issue with the site that I found is that there are a lot of private groups, but because they're private, nobody knows they exist. So you don't know that, hey, there's a group out there about PRISM that you might want to join, because there isn't anything that says, here's a list of the private groups you could ask to join. At least I didn't find such a thing. There might be something, but I don't see it there. So you can't ask to join what you don't know exists.
Let me jump in. This is Lee Willis. I'm the NPIN project officer.
Hey, Lee.
And hey, how are you, Mary?
I'm good.
And hello, everybody. Sorry, I was lurking on the call, I guess, waiting for my time to interject. But one of the things that we've explored with that is to create 3 different levels of privacy for NPIN groups, meaning that there would be groups that would be truly public, and then Of course, you'd have to log into the site to actually be able to, see them. We would have groups that as you're describing, Mary, that would be private, but you would have the ability to know they exist. And then we would have a third option that would be, for lack of a better phrase, private, meaning that you would not know that the group existed unless you were actually a member. So we are trying to work on that so that you would be able to see groups that, while private, but you would know that they would exist.
Yeah, I think that's a good idea, and I think even if at least initially, just check with the groups that wouldn't mind having them listed as, these groups are up there. You still have to get special permission to join, but where you just have a little, box that when you log into the general site saying, if you're interested, contact these people for access to a private group that wants to be known. So that's a good idea. Go ahead, Mary.
That was it. I just wanted to say that there's probably a lot of groups that I would join and listen in on if I knew they existed, but then maybe they're all hiding. I don't know.
Other comments from people? What's worked and what you've been frustrated about?
So this is Sandra from Maryland, and I know that others here probably use it more than I do, and I think what I get frustrated with is the logging in and then the slowness of the site. So it really makes me, I guess we're all spoiled these days where if things don't load in less than 3 seconds, then I'm like, I've had enough. So I find that the site runs pretty slowly, and that's frustrating.
Okay, absolutely. And just to make you all aware, we've been frustrated as well with the speed of the site and the robustness of the site, but our contractor has been working, overtime to make sure that the platform is not only stable, but will be really responsive. So we hope to see those improvements in the next, 30 days or so.
Thanks, Lee. Listen, we got about 7 minutes or so. So if you guys have any other comments or complaints about the NPEN site, you can get in contact with me. This is Marvin again, and you'll get my phone number as well as email address at the end of the call. Let's go ahead.
I think we can take probably another minute or two, just because I think this is a great opportunity for Lee and others to sort of hear what some of the issues are from our users.
Yeah, that'd be great, Charlie.
I know for me, I think a couple of things is the constant changing of passwords, and then sometimes when you go to change your password, it won't let you, and then it won't send you a follow-up password to change your password. So I think somebody really needs to look into that whole password process, because I've heard from a number of people as well as myself that's really been frustrated. I think as you mentioned, Marvin, I think a big thing is when people post resources or have a conversation, I think it's really important to be able to, if I have another, I reply to that conversation and not have to start a new conversation. So I think that is a really, really important thing that needs to be fixed really quickly. But anything else from our users? And if you have anything great to say, we're also interested in that. Again, it's not a perfect tool, but it has been a useful tool in getting information out to people, as well as when people have had some questions, we've gotten some really great response and some great conversations, not only around PRISM stuff, around other stuff. So, as they say, don't let the perfect be the enemy of the good. I think it's something we always want to try to be enhancing, but if somebody, if the system's been helpful to people, we'd also like to kind of hear that too.
This is Sandra from Maryland again, and I would say that it does have a potential to be a really great resource, and I think it's already kind of starting to be. I know that I remembered there was like a discussion sometime over the last 6 months about whether a PRISM profile ID was PHI, and when that kind of question came up here in Maryland, I went back to NPIN and found that discussion, that thread, and read up on it to kind of help me inform what was going on here in Maryland. So it's definitely a budding resource.
Great.
Great comment.
Yeah, and I think the other thing is, the site is going to be successful or unsuccessful really based on the usage. So the more people use it, the more value it's going to have. So I think, it does take some initial investment on all our parts to take the time to post and also to respond to posts. If you see a post that's helpful, just tell that person, hey, that was helpful. That you don't have to write a book about it. But I think giving people feedback on posts is really important because, right now we're not getting a lot of analytics on the site usage, but I think irregardless of that, I think people would like to know that, hey, from my investing a little bit of time to share a resource, somebody actually got some value out of that. So any final comments or questions before we sort of wrap up? I got a couple more things to go through.
There was an additional question that I did need to ask of the group that was put to me just before the call started. It seems that several times we fill up the hour, even though it doesn't seem like the hour is that long. And the question was put, should we extend the time of the meeting from 1 hour to either an hour and a half to 2 hours? Does anyone have any thoughts about that, or do you think that 1 hour is fine and we can just deal with the spillage as needed?
Yeah, I would vote for like 1 hour, or maybe like 1 hour and 15 minutes, but I think an hour and a half or 2 hours would probably be too much.
Any other comments on time length?
Yeah, I agree. I think an hour is good, but I think there have been some times where we've had really good discussion or a presentation's gone on longer, and there's no problem with, us keeping the line open and we don't get shut off at that hour. And I think
that people prefer to have it as an hour.
I have
if
questions.
Really is interesting,
we can do that.
Keep talking, and then but saying an hour 15 means you'll go to an hour and a half at some point. So
that's true.
That's the nature of meetings.
Yeah. Scope creep.
Okay, so just so we can wrap up on time, keep to our hour, a couple things. As you know, we do have a users group participant list. And we send out that periodically, so I'm going to send it out probably this week. If you could just take time to check the information for your project area, make any corrections, tell us if anybody's dropped off, or if you have somebody new to add, or your phone number or title has changed, because that list again is really useful, and we make it available to everybody, and we'll get that out to you. If you have any suggestions for topics or questions that you would like us to cover, again, you can always post them in NPIN, but send us, Marvin or myself, an email, and we'll go ahead and do that. We, again, encourage everybody to use the NPIN site. We think it's a great resource and a great way to get questions asked. We will be posting the slides from today, and Sandra and Marcia have given us a PDF version of their slides. We'll do the whole presentation. Will be up on NPIN by the end of the week, hopefully the end of the week or early next week, as well as a link to we record these sessions. So for those people that weren't able to make it, or we kind of talk fast and they want to hear a certain part, we'll be posting those. So those are going to be available this week. And so if you could just take a second with some feedback, and we've kind of made it really simple. Was today's call helpful to you, or wasn't it? And if it's not, maybe email us and tell us why it wasn't helpful and what we can do. And if it is, let us know, and we'll continue what we're doing. So we'll take a quick second and look at that. So at least for over 90% of you, hopefully today's call, you got something out of it. And again, I think just the opportunity to be able to hear from other people that are using the same system that you are and having the same challenges as well as successes. It's always a great opportunity. This is just one of our tools to help enhance surveillance systems. It's not the only tool. There's other ways to do this, but again, it's just another NCSD and CDC are really partnering along with ASD to really work well with everybody and to make sure that we get you the help that you can to have the best system. So with that, I think we're going to wrap things up.
Thanks, everybody, for attending.
Feedback. So with that, I'll sign out and have a great week and talk to you next meeting, which will probably be in about 3 months.
Thanks so much from Colorado.
Okay, thanks. Appreciate it.
Hey, Charlie, you want to give me a minute and give me a call at my desk?
Okay.
Thanks.